Moving on to Augar Zageche Dukhne, chronic constipation. For this, we have our first chairperson as Dr. Sandhya Bhate. She is MBBS DNB General Surgery, Medistar Hospital, FMAS, FIAGS, FFIAGS, Consultant Laparoscopic Surgeon and Anorectal Surgeon. Dr. Sandhya Bhate, may we have you on stage, please? Oh, I'm so sorry. To join her, we have Dr. Sampada Tambolkar. She is MBBS MD Pediatrics, MHPE Maastricht University, Netherlands, and Professor in Pediatrics at Dr. D.Y. Patil Medical College, Pune. Requesting you to please introduce the speaker.
Good afternoon, all of you. Thank you all for being here today. It gives me immense pleasure to introduce Dr. Prasad Bhate, sir. He is a well-known gastroenterologist, having experience of more than 15 years in this field. He has done his MBBS from Mumbai. He has done his MD medicine from BJ Medical College, Pune. He has taken a fellowship in advanced therapeutic endoscopy from Sydney, Australia. He has done his DM gastroenterology from Mumbai. He is also a founder and director of GI Motility Lab and liver transplant program in Manipal Hospital. Apart from his outstanding academic career, he is also interested in sports and reading novels and motivational books. Saranna Marathi pustaka वाचायला खूप आवडतं, right, sir? So, ladies and gentlemen, please welcome Dr. Prasad Bhate, sir, on stage to present a topic on chronic constipation.
थँक यू व्हेरी मच. पुस्तकांच्या बाबतीत आम्ही आता 16 ऑक्टोबरला माझ्या बड्डेच्या दिवशी आम्ही कम्युनिटी लायब्ररी सुरू केली आहे मणिपालमध्ये. तर सगळ्यांनी तिथे येऊन फ्रीमध्ये पुस्तकं वाचावेत असे मी लेक्चर सुरू करायच्या आधी सगळ्यांना विनंती करतो. तर सर्वप्रथम थँक्यू व्हेरी मच ऑर्गनायझिंग कमिटीचे अभिनंदन की त्यांनी सक्सेसफुली ही चांगली कॉन्फरन्स ऑर्गनाईज केली आणि मला संधी दिली इथं बोलायची. आपला टॉपिक जो आहे तो आहे क्रॉनिक कॉन्स्टिपेशन. तर बदानी सरांच्या बाबतीत पेशंट लगेच जातो वरती किंवा त्याला त्रास होत नाही. पण आपलं जे आहे क्रॉनिक कॉन्स्टिपेशन पेशंट रोज तुमच्याकडे येतो आणि जात नाही कुठं. टॉपिक आहे क्रॉनिक कॉन्स्टिपेशन आणि रोल ऑफ ॲनोरेक्टल मॅनोमेट्री आणि बायोफीडबॅक इन क्रॉनिक कॉन्स्टिपेशन. तर ॲट मणिपाल हॉस्पिटल पुणे वी हॅव स्टार्टेड समथिंग कॉलेज GI मोटिलिटी लॅब. तर GI मोटिलिटी लॅब म्हणजे काय मी आधी सांगतो. तर वी ऑलरेडी नो द एंडोस्कोपिक इव्हॅल्युएशन ऑफ GI ट्रॅक्ट. वी डू अप्पर GI एंडोस्कोपी, कोलोनोस्कोपी, ERCPs, small bowel endoscopy, capsule endoscopy to find out whether there is any structural problem in the GI tract. In upper GI endoscopy we find out tumors, we find out varices, we treat them. In colonoscopy we find colonic cancers. We look for other diseases like telangiectasias. But what about the function of these organs? So in chronic constipation, most of the times colonoscopy is normal. Still patient has constipation and symptoms and he is suffering and we don't know what to test for. So in GI motility lab, we test the function of our GI tract. So we have a small catheter which is put either through the nose into the esophagus or through the anus into the rectum, and it has pressure sensors which are there is a transducer which converts these signals into the graph. We have a color plot which tells us the pressure in either rectum or in anal canal, and in the case of esophagus in the mid esophagus and ileus. So this is an example of that color plot. So we get the pressure changes, time, distance from the nares in this graph. So on the left side, it's a esophageal manometry. Before going to constipation, I'll explain about esophageal manometry. A catheter is passed from nose into the esophagus. The graph on the left side shows normal swallow. We can see the pressure changes going from upper esophagus to lower esophagus and ileus relaxing nicely. The graph on the right side shows a case of achalasia cardia where the lower esophageal sphincter fails to relax. Classically, this patient had symptoms of dysphagia. Upper GI endoscopy was normal and we performed esophageal manometry to diagnose this case. Once the achalasia was diagnosed, we treated with per oral endoscopic myotomy and patient is doing well now. So he was roaming around for a year with normal endoscopy reports and symptoms of dysphagia. So every every doctor who used to see him, after upper GI endoscopy report was normal, he used to treat with some antacids and prokinetic drugs and let him go, and patient was not getting better. So in endoscopy, we see the structural changes. In manometry, we see the function of the organ, and it is basically the physiology of the organ which we examine. So in esophageal manometry, we see the luminal esophageal pressures, then peristaltic movements, bolus transit. We can time it with the swallow. Then it is useful in case of dysphagia, non-cardiac chest pain, and prior to any anti-reflux surgery, that is fundoplication, we have to do the esophageal manometry to rule out, to make sure that esophageal motility is present, so that the patient doesn't come with dysphagia after surgery. So what are the other tests done in GI motility lab? So we have seen that high resolution manometry, which we can use for esophagus. We have another catheter which is used for rectum and anus, that is anorectal manometry. Then this same machine can be used for biofeedback, which we are going to see in next few slides. We have 24-arch pH metry and impedance metry. So it is for acid reflux and non-acid reflux. Again, for small intestinal bacterial overgrowth, we have hydrogen methane breath testing. For chronic constipation, we have colon transit time study. Another test which actually our center is doing first in Pune is electrogastrography. Just like ECG, we have electrical movement occurring in stomach, and we measure it by EGG. So practical implications are EGG are like in patients of gastroparesis. Those patients who have chronic diabetes mellitus, uncontrolled diabetes mellitus, they develop GI motility disorders, gastric fullness, vomiting, and we can diagnose gastroparesis by EGG. Another test which we have is capsule endoscopy. Because our scopes cannot reach small intestine, we have to use a capsule which has a camera to see whether any lesion is present in the GI tract. So this is a sample of, this slide shows how colon transit time is done. So basically we ask the patient to swallow some barium tablets and take serial x-rays to find out whether the pellets reach the rectum in time. So this is a question for crowd. Who is this? He is a very famous fellow, freedom fighter and philosopher. Good. So what is picture of Vinoba Bhave doing in chronic constipation lab? So we all know that he was a great philosopher, but his famous quote is Prabhate Maladarshanam. That is, every morning you have to see your stools to see that you are healthy or not. Unfortunately, सगळ्यांनाच हे सुख मिळत नाही आणि ते आमच्याकडे येतात. तर कॉन्स्टिपेशन म्हणजे काय? पेशंट काय सांगतो की पेशंटला GI रिलेटेड काही सिम्पटम असेल तर तो कॉन्स्टिपेशन म्हणून येतो. म्हणजे त्याला रिकरंट बर्फ जरी असतील तरी तो म्हणतो की मला मोशन पास झाले नाही म्हणून बर्फ्स येत आहेत, किंवा ब्लोटिंग झालं तरी पण तो म्हणतो की मला बर्फ्स येत आहे. तर ACG, अमेरिकन कॉलेज ऑफ गॅस्ट्रोएंटरॉलॉजी काय म्हणतं, तर कॉन्स्टिपेशन इज डिफाइंड ॲज इनफ्रिक्वेंट स्टूल्स, दॅट इज 3 per week, or difficult stool passage, or both. So what do you mean by difficult stool passage? That is, patient has to strain for passing stool, patient has a feeling of incomplete evacuation, hard or lumpy stools, hard stools, prolonged time to pass stools, need for manual maneuvers like finger evacuation to pass stools, a sense of difficulty in passing stool. Everything is happening but he doesn't feel happy about it, and unsatisfactory defecation. आणि त्याला हे समाधान मिळवून देण्यासाठी आपण बायोफीडबॅक वापरणार आहोत. तर ऑब्वियसली इट इज नॉट अ लाईफ थ्रेटनिंग कंडिशन, बट पेशंट सफर्स. आणि होतं काय की ओव्हर द पिरियड दे ॲट्रिब्यूट एव्हरीथिंग इन देअर लाईफ टू द कॉन्स्टिपेशन. सो कॉन्स्टिपेशन, व्हेन पेशंट कम्स विथ सिम्पटम्स ऑफ कॉन्स्टिपेशन, वी हॅव टू टेक हिस्ट्री. ऑब्वियसली बिवरे सरांनी सांगितल्याप्रमाणे की डायरेक्ट कोलोनोस्कोपीला न पाठवता आधी त्याची हिस्ट्री घ्यायची. वी हॅव टू फाइंड आउट द रूट कॉज. सो कॉन्स्टिपेशन कॅन बी प्रायमरी, दॅट इज इडिओपॅथिक, ऑर सेकंडरी. तर सेकंडरी कॉजेसची खूप मोठी लिस्ट आहे. त्यामध्ये मेटाबॉलिक डिसऑर्डर्स लाईक हायपोथायरॉइडिझम, GI पॅथॉलॉजीज लाईक कोलोनिक मास, endocrine disorders, neurologic disorders, some medications who have side effect of decreasing colonic mobility. हे सगळे आपल्याला हिस्ट्री घेऊन रूल आउट करायला पाहिजे. हे जर कुठलेही फॅक्टर नसतील तर वी लेबल दॅट पेशंट ॲज क्रॉनिक इडिओपॅथिक कॉन्स्टिपेशन. क्रॉनिक इडिओपॅथिक कॉन्स्टिपेशनचे 3 प्रकार आहेत. एक तर आहे डिफिकेशन डिसऑर्डर, स्लो कोलोनिक ट्रान्समिशन, आणि नॉर्मल कोलोन ट्रान्झिट टाईम कॉन्स्टिपेशन. आता डिफिकेशन डिसऑर्डरमध्ये ह्या ॲनोरेक्टल मॅनोमेट्री आणि बायोफीडबॅकचा रोल आहे. ते काय आपण ते बघूया. सो दिस इज द लॉंग लिस्ट ऑफ causes of secondary constipation, we have to find out, look for them and treat them so that 90% or 50% patient will get cured. When the patient comes with symptoms of constipation, we have to actively look for red alarm features. What are those? Hematochezia or bleeding PR, iron deficiency anemia, hemoglobin will be low and MCV will be on the lower side. Clinically significant weight loss, which is defined as more than 5% of usual body weight over the period of 6 to 12 months, that is significant weight loss. New onset of unexplained constipation, obstructive symptoms like patient says that there is incomplete evacuation, and if there is family history of colorectal cancer or IBD, inflammatory bowel disease like ulcerative colitis or Crohn's disease. If your patient has any of these alarm features, I am happy to do his colonoscopy, and this patient should be evaluated for any GI pathologies. So again, one more thing which is missing in this slide is age more than 45 years. If a patient who is more than 45 years has recent onset constipation, we should evaluate him for GI pathology. Like we have to rule out basically colonic malignancies. Colonoscopy is the best screening tool for that. Now we have ruled out the secondary causes. We have done colonoscopy. Everything is normal. Still the patient has chronic constipation. Then the role comes for anorectal manometry and balloon expulsion test. Routinely, I advise those patients to increase fiber diet, do Kegel exercises, that is pelvic floor muscle strengthening exercises, increase water intake, fiber intake, and while using commode, he has to take a stool below his feet so that knees come up and the posture is more physiological. After that, we post this patient for anorectal manometry and biofeedback. So we have seen that most of the patient with this constipation with no alarm features, that is functional constipation, has defecatory disorder. So what are the symptoms for that defecatory disorder or obstructive defecation? Frequent staining, incomplete evacuation, need of manual manures, that is finger evacuation, is associated with defecatory disorders. It is also associated with pelvic floor dysfunction, descending perineum syndrome, and rectal prolapse. The best test to diagnose this defecatory disorder is anorectal manometry, and very simple test is balloon expulsion test. I will explain the balloon expulsion test in the later slide. So to pass motion in a complete way, there has to be a coordinated action of rectal muscles and pelvic floor muscles. So the puborectalis and external anal sphincter should relax while the patient is bearing down. If this action doesn't happen together, patient feels that he cannot empty his rectum. So धरण भरलेलं आहे पण दरवाजे उघडत नाही, त्यामुळं मोशन पास होत नाही असं आहे. तर या फिगरमध्ये ते सांगितलेलं आहे की rectal muscle has to contract, he has to bear down, he can use his abdominal muscles to create increase intra-abdominal pressure, and pelvic floor muscle should relax, that is anal muscle should relax. If this doesn't occur simultaneously, he will have defecatory dysfunction. So what are the causes? So exact cause is not known, but many pelvic diseases or anorectal diseases will lead to painful conditions, and because of that, patient will develop a habit of not relaxing the pelvic floor muscles and will lead to chronic constipation. So how do we know that this is defecatory disorder, patient is not relaxing the perineum? So this is a very simple test called anorectal manometry. We have a catheter which has pressure sensors. It is not like a colonoscopy. It is not a big catheter. It's a thin catheter which is passed through the anus into the rectum. And we have pressure sensors. We have a graph which tells us which muscles are contracting and which are relaxing. Another test is balloon expulsion test. So at the tip of this catheter, we have a balloon which we inflate with 50 cc saline, and we give a timer to patient and ask the patient to expel this balloon in one minute. If he is not able to expel or excrete this balloon within 1 minute, it tells us that patient has a defecatory disorder. Now this is what I see on the anorectal manometry graph. First one, the top one is normal, where the rectal muscles are contracting, which is shown in red color, and the perineal muscles are relaxing, which is shown in green color. The lower graph is of defecatory disorder patient, where he is not relaxing the perineal muscles and the pressure in these muscles is paradoxically increasing, and that is the problem. So there are 4 types depending on which muscles are relaxing or not relaxing and which muscles are contracting. That is not important. Important is patient should understand his physiology, what is happening, and we can teach him to relax those muscles by biofeedback machine. Now, till date, fiber was the only treatment available for fiber or laxatives was the only treatment available for this patient. But if he is not able to relax the perineal muscle, he will not be able to pass the motions. So this is a randomized clinical trial which shows that biofeedback is more effective and has more sustained results than the fibers. Again, another trial, it is saying that biofeedback is the preferred treatment for constipated patient with dyssynergia that we have seen. So rather than giving fiber, this patient should be posted for biofeedback. Now, how biofeedback is does? Because we understand the physiology, the technician understands the physiology, but the patient doesn't understand what is happening. So we have to show the patient the graph and explain him that which muscle he has to contract and which muscles he has to relax. So it has to be done over the period, and it's called as operant conditioning. So it's a very classically behavior modification of the patient. It takes time. We have to develop rapport with the patient, and it will not happen with a stick. That this is your graph and relax this muscle, this will not happen because those are involuntary muscles. So what we do, we first explain the patient what is the physiology, which muscles has to be relaxed, which muscle has to be contracted while passing the motion. We show the graph to the patient, and we ask the patient now to do the exercises like bearing down, push maneuver or hold maneuver or squeeze maneuver, and we ask the patient to repeat it for 1 hour. Then we let the patient go home and practice it at home, and we have to repeatedly do it for 5 to 6 times to get the best results. Now, studies have shown that the results are more than 80%, but in practical, in our day-to-day practice, we see that more than 50% patients will get good results. Those patients who cannot understand this physiology, or they have a fixed mindset that nothing is going to happen, he is going to be constipated for his life, they won't improve. So this is what I see on the biofeedback graph practically. So there is a picture of rectum and anal canal, and there is a live graph going on the left side, where the black color is high pressure. We ask the patient to convert it to the lighter colors. There is a pressure graph of anal pressure on the left side, which he has to decrease, and there is another graph where of abdominal muscles and rectal muscles, which he has to increase the pressure while bearing down. We also give auditory feedback to the patient, but it is a learning process. So we have to be patient with our patients. So this is it. Take home message is endoscopy and GI motility testing are complementary to each other. So your patient is constipated, but he might have a mass in the rectum. So we have to do colonoscopy, rule out organic disease. If it is functional constipation, then we have to evaluate for dysfunction. Endoscopy and GI motility lab are complementary to each other. Any red flag sign, we have to do colonoscopy. Your patient is anemic, has bleeding PR, then it's not a functional disease. We have to find out the cause and treat the cause. And for dyssynergic defecation, which we just have found, many patients, they get benefit from biofeedback, and now it is the preferred treatment of choice rather than giving laxatives. So thank you very much for patient hearing. We have a helpline. हा माझाच नंबर आहे. तर कुठल्याही GI ब्लीडला, लिव्हर फेल्युअरला आणि कॉन्स्टिपेशनला तुम्ही कॉल करू शकता, कधी करू शकतात. दुसरं म्हणजे मी हाय फायबर डाएटचे जे चार्ट आहे तो तुम्हाला सगळ्यांना पाठवणार आहे, व्हॉट्सॲप करेल, आणि जे केगल एक्सरसाइजच्या लिंक पाठवेल पेशंटसाठी. तर आपल्या सगळ्या पेशंटला ते आत्तापासून सुरू करा, आणि दे विल गेट हेल्प. थँक्यू. आम्ही कालच मी जॉईन झाल्यापासून 100वी ERCP मी काल केली मणिपाल हॉस्पिटल बाणेरला, आणि फॉर्च्युनेटली सगळे पेशंट व्यवस्थित आहे. आता उद्या त्याच पेशंटची कोलेसिस्टेक्टॉमी आहे. थँक्यू सर. थँक्यू.
थँक्यू डॉक्टर प्रसाद. इट इज एन एक्सलंट प्रेझेंटेशन, आणि कमी महत्त्वाचा नाही, एक अख्खा बॉलिवूड पिक्चर झाला आहे त्याच्यावर. सो नेक्स्ट टाईम आय थिंक अमिताभ बच्चन सरांचा फोटो लावायला हरकत नाही. जस्ट वन क्विक क्वेश्चन इफ दे कॅन अलाव. Can the manometry be used in pediatrics, and if yes, in what age group? Because we have a lot of GERD patients.
So I am an adult gastroenterologist. I am not a pediatric gastroenterologist, but it is the treatment for pediatric population. Actually हे सगळे बिहेवियर आहेत हे लहानपणीच चालू होतात. because we ask our children to hold stools कारण सोशली इट इज व्हेरी ऑकवर्ड टू पास टूल एनिवेअर अवेलेबिलिटी नसते टॉयलेटची आणि त्यामुळं ते लर्न करतात हे बिहेवियर टू होल्ड आणि तेच परसिस्टंट राहतं. सो पिडियाट्रिक इवन द अप टू डेट सेज की पिडियाट्रिक पॉप्युलेशनमध्ये इट इज द ट्रीटमेंट ऑफ चॉईस. तर
इन्फंट्समध्ये पण होऊ शकतं
ऑब्वियसली, पण इन्फंट्समध्ये काय होतं, वी नीड सम कोऑपरेशन फ्रॉम पेशंट्स टू फाइंड आउट. सो फॉर डायग्नोसिस इज ओके, फॉर ट्रीटमेंट इन्फंट्समध्ये पॉसिबल नाही आहे, पण यंग चिल्ड्रेन दे लर्न इट फास्ट आणि जर ते लहानपणापासून आपण ट्रीट केलं तर ॲडल्टमध्ये ते येणारच.
थँक्यू.
Thank you, Prasad. May I request the chairpersons to please honor the speaker? Now calling upon stage Dr. Suvarna Salve, the founder member of BMA, to felicitate our chairpersons. Rahul Chaudhary.